And Steve, you're live.
Okay, good afternoon, everybody. Welcome to a rainy Friday afternoon presentation on telemedicine. As you see, our topic today is telemedicine. This is a Rhode Island CLE webinar. You have two presenters today. This is Steve Zubiago speaking. I'm a partner with Nixon Peabody, where I practice primarily healthcare law, and I do a range of issues for healthcare providers, corporate and regulatory work. I was going to ask my partner, Bill Wynne, to introduce himself. He's sitting next to me in a conference room here, but we've muted his mic so that we don't get static. So I'm going to introduce him. Bill is a litigation associate with our firm, where he works on a range of issues, including white-collar matters, including many matters related to healthcare, and he'll be talking to you about enforcement action and white-collar matters related to telehealth after I make some presentations. So you're going to be entitled to one credit if you hang out for 50 minutes with us. Bill and I would both prefer to do these interactive with an audience where we could look at you and ask questions. Unfortunately, we can't. I'm told that there is a chat box that you can submit questions to if you'd like to do that. We'll try to answer them as we go along. And, of course, our email information is available, and I'm sure you can reach out to us with any questions. So with that, I'll get started. So on my agenda, I am going to cover essentially three things, three broad categories. And I'm struggling to make the slide move. Okay, I'll get some help on that, I'm sure. So the three areas that I'm going to cover are the basics and foundation, are essentially an overview of telemedicine and its role during COVID. And then I'm going to offer you some predictions about the future of telehealth, as you see there on the slide. And then Bill will talk about the government investigations. Next slide, please. And so in the overview, I'm going to talk about three things, the basics and the foundation. I'm going to talk about how telehealth expanded. And then if we have some time, I'm going to speak about telehealth and digital deals and some key issues that come up in those transactions. But I'm going to spend a lot of time on the basics and the foundation and then the expansion. So next slide, please. So you can actually, you can advance one more slide. So let's talk about what, just define our terms as lawyers are often want to do. So first, there's a state that defines telehealth as you see, and the key word there is mode. It's a way of delivering health care. It's not a different type of health care. It's a way of delivering health care. And then the related term telemedicine, as you see defined, is the use of medical information exchanged from one site to another using interactive telecommunication equipment that includes, at a minimum, audio and video, permitting two-way real-time interactive communication between the patient and the physician. So often you'll see telemedicine either conducted over the phone, over video equipment, over Zoom, or over a medium like we're using now. So when you're talking about telehealth, it's a mode of delivering healthcare services. Telemedicine is something that you've got that two-way relationship of back and forth. Okay, next slide, please. And as I mentioned, telehealth is not a distinct type of healthcare. It's a mode of delivering healthcare. Next slide, please. So now there are four modalities of telehealth that I want to explain. And you'll see that these are all different and diverse areas of telehealth, and each are grown into significant businesses. And in preparing for this talk, I just Googled each of the four categories and saw what I got. And you can see all the big boys are in this. Samsung is into this RPM stuff big time. Every big name technology player and healthcare player is involved in these. So let's break down these four modalities for you. So the first is, and you can switch the slide, please. The first is synchronous or live video. And as you see, that's two-way interaction between a person and the caregiver, and usually you have audio-visual back and forth. It's what people think of when they think of just pure, simple telemedicine. And as I say on the quote on the side there, it's not just a one-way telephone conversation or an email or an instant message. It's got to be two-way. It's got to be interactive. You can ask a question, get an answer. That's synchronous or live video. And as I'll talk about with the advent of COVID, what you're finding often is you're seeing a lot by telephone back and forth, and you're also seeing as technology improves in provider organizations, some type of visual capability as well, similar to what we're doing here. So that's synchronous. Then next slide, please. The next is asynchronous, which is also known as store and forward. So in this type of telehealth, you've got the transmission of videos and digital images through secure communication that's recorded and captured and then looked at somewhere else. This has been going on for quite some time. And the best example of this is in the area of imaging, radiology, MRIs, and me and the healthcare team at Nixon, we do a lot of work for young doctors starting out, as well as senior well-developed groups. But the young doctors starting out, the joke is that everybody wants to be a radiologist. And they want to be a radiologist for a couple of reasons. One, they don't have to deal with patients. Two, it's kind of an easy job. Three, you get to watch TV just like you do when you're a kid. But four, and most important, is you don't have to get out of your pajamas. You can do it from home. You can read the slides from home on a video screen. And a ton of radiology, and I want to add high-quality radiology work is performed by radiologists reviewing images remotely. There is just absolutely no clinical reason that they need to be close to the imaging equipment that takes the slides. As long as that imaging equipment is operated well and successfully, and the image is clear, that image can be reviewed remotely. And when you stop and think about it, it opens up a ton of issues because, my joke, of course, is that they can stay in their pajamas and stay home. But when you think about it, they don't have to be in the same state. They don't have to be in the same country. They don't have to be in the same time region. And that starts to really get at issues of quality, where you can search around for the best reader anywhere in the world. And it also gets at the issue of price. You can search around and work with a wide range of potential viewers of the scan to obtain the best price. I'm here to talk about telehealth. I won't get on my healthcare reform soapbox, which I often like to do, but quality and cost are the two main issues in healthcare. We need higher quality care because that's lower cost, and of course we need lower cost healthcare because the cost of healthcare is breaking our system and our economy. So anything that can improve the quality and impact the cost is of course good. And this asynchronous telehealth is an area that you see a lot of activity in. This is not new. This is not just COVID-based. This is something that's been going on for a long time, and I think you will see more and more of that. Okay, thank you for the next slide. So now I want to talk about remote patient monitoring, RPM. So as you can see in the slide, this is the collection of personal health data from an individual, and then it's transmitted to a provider in another location. This is something that can take place both in real time or not in real time. So, for instance, some of you may experience this. My experience is with my dad. He has sleep apnea. He has a device that he uses at night, and it records his sleep habits, and then he gets a report on that. That's an example of RPM. It's recording his sleep habits. It's beamed to an office. That office records it. And then when he has an appointment with either the technologist or the physician, they review those reports about his sleep habits and make recommendations about what he should be doing. Sleep is one example. You certainly see it in the areas of heart monitoring, diabetes, anything that needs to be monitored. And what it allows is it allows real-time, up-to-date information, and it allows the provider to determine whether or not they need to review that information in real time, in many time intervals and long time intervals, but the data is recorded and there to come back on. And that has become an important part of treating any patients with any type of long-term chronic type issue. Then next slide, the fourth type of telehealth is mHealth. And the M, of course, standing for mobile. So that's when a mobile device is used to receive a health service or education, usually through an app. And on this one, I want to actually focus on using a device for an educational purpose. There are a ton of companies out there, and one I was involved with recently, with the sale of the company, where their sole business was to create online caricatures that demonstrated all the steps in the healthcare process. So a patient could access it and say, I'm going for back surgery. And they could provide information about their back surgery, and it would work them through a video in cartoon form about what to expect. And it was interactive in the sense that the patient would provide responses to questions, and then that would lead them down a different path that would provide information. It was extremely high tech, extremely well done, extremely detailed, and it gave the patient a real feel that he or she were getting their questions answered, and they could delve further and further. And it got to a high level of detail. And if they reached a point in the decision tree in the cartoon where the questions couldn't be answered anymore, there was a way to submit the question and have a healthcare professional answer him or her. So this mHealth is something that, again, is proliferated during COVID, but has really existed before COVID, and it's another way that people are using technology to receive healthcare services. So those are the four issues, the four types of telehealth that we see. So if we were in person, I would pause and look everybody in the eye and ask if you have any questions, but I can't do that. I don't see any chats, so I'm going to keep going to the second part of the presentation. And that is telehealth, the expansion of telehealth. So I'm going to talk about this just in general, and then I'm going to try to talk a little bit about how this has worked in COVID. So the drivers of telehealth are, first of all, there's a healthcare provider shortage nationally and certainly in Rhode Island. And anybody who doesn't have a primary care doc and needs to get a primary care doc, you're seeing that. You're understanding how tough that can be. Specialists, a little more prevalent, but some specialties are more scarce than others. But certainly, people have trouble accessing high-quality physicians. And you see, as I talked about all the different modalities of telehealth, one, getting outside of the region and opening up, or even outside of the country, opening up more providers being able to provide care. Second, obviously, we're having a ton of digital health innovation, different ways of providing telehealth, and that's driving. Big data, electronic health record, interoperability, all big words. You could take, month-long classes on this. But essentially, big data is the concept of the improving ability for us to store and sort through huge amounts of data. And that's important for healthcare, not only because healthcare is very data intensive, but also to use that data in a way to improve modalities and improve treatment. You have to be able to search and retrieve that data. And the technological capability to do that is getting more and more. Then electronic health record interoperability is the fancy word saying that electronic health records that can talk to each other. So I'm sure you're all aware that there's a big push to get away from paper records to electronic medical records. They're cheaper. It allows for more sharing of information. But the most important point in electronic health records is that the systems can talk to each other. And when this started developing, you heard that one hospital system would have Epic, and some hospital system would have something else, and they would have trouble speaking. Well, as all this is coming more and more, you're getting more and more the ability for those health systems records to be able to speak to each other, and you're getting more and more the ability to share that information. In Rhode Island, we have the current care system. That's a well-developed system. We're getting more and more people on it. That's a way that both health systems and physicians and other healthcare providers can share records, and we're seeing more and more adoption of that as time goes on. Another driver of the telehealth expansion is consumers. Consumers are absolutely positively demanding these changes. Everybody wants to do everything on their phone. Everybody wants to do everything at home. People don't want to go out to appointments. And so consumers are demanding it. And when consumers demand it, it's something like healthcare that everybody uses, the market will respond, and the market is responding. And then finally, the change that is very significant is you're seeing expanded reimbursement by private payers and government payers. So obviously, if the payers are going to start paying for telehealth services, providers will be more incentivized to use them. And in fact, what is happening is the payers are seeing that they can use telehealth as a way to provide high quality care at a lower cost. I represent a bunch of cardiologists, and I've asked them how they use telehealth, and they would say that a patient with a heart condition that they need to monitor, without telehealth, the only way to monitor that patient is to have the patient come in. And once you've got the patient in the office, unless you're in a quality reimbursement system, where by that I mean a system where you're getting paid for quality, if you're getting paid for fee-for-service, if you bring the patient in, you've got every financial incentive to do as many things for that patient. Conversely, if it's just a monitoring call and the patient has some type of device on them, that the RPM devices that I mentioned, and that device is providing information to the office, and you just need to ask some questions to monitor how he or she is doing. My cardiologist friends were telling me that telehealth is actually a great way to keep in touch with a patient on a monthly or bi-monthly basis with that remote monitoring. Be able to check and not have to have the patient come in, quicker time, easier scheduling. In the COVID arena, not dragging another patient into the office, of course, which is a safety issue. For older patients, less risk dragging them out of the house. And it just seems to be a win-win, and the government is expanding reimbursement for that. As I mentioned, we do a lot of work for providers, especially physicians. I will say that reimbursement is not what they want it to be. It's still light. You still get paid much better if you see the patient in the office, but that is changing, and it is an incentive to drive telehealth. Next slide, please. So these next series of slides are going to talk about the expansion of telehealth at different levels of the healthcare system. So the first I'm going to speak about is health systems. And a health system is typically a group of hospitals and other providers. Here in Rhode Island, of course, the big health system is Lifespan. Care New England is another large health system. Charter Care is another one. And they have hospitals, they have home health agencies, sometimes they have surgery centers, they have nursing homes, systems that provide the range of care. So what types of things are they looking for out of telehealth, these large health systems? So first, they want to support chronic disease management. So chronic disease is any disease that's long-standing By chronic, it's meant it's over time. It's not something that can be cured with one pill, one operation, one quick therapy. It's something that needs to be treated over time. So, of course, when you have anything that needs to be treated over time, in a typical healthcare model, that would mean a lot of patient office visits, a lot of contact. Where telehealth with this, at the 4 levels that I spoke about, the remote monitoring, the meetings by phone or by video, you can have a lot less direct contact quicker and still get the same information. And in fact, they're finding that they can have more contacts, obtain more up-to-date information because they can do those contacts quicker. It frees up time. And again, you're starting to see reimbursement for it. Next, from the data management perspective, because telehealth is all computerized, electronic, in a way that you can gather data, it makes it much easier to obtain data and to manage data. When you have a face-to-face interaction, a lot of times you had healthcare professionals handwriting charts. As we've evolved away from paper records into electronic medical records, someone's still got to sit there and type it. But when you're having the type of communication at the 4 levels that I talked about, that data can just be grabbed through the process, maintained and grabbed and used with a lot less effort. You're seeing health systems expand their consumer focused care options that can be educational and other types of matters. But you see they're using this telehealth as a way to reach out and a way to increase their patient base. Another way is to increase the geographic reach. Here we talk about supporting rural providers and communities. That's not something we deal with here in the fine state of Rhode Island. But of course, it could mean that increasing the reach, if you have the best person for reading knee X-rays, you're not limited to just reading knee X-rays from people from Rhode Island. You can sell that service all over the country, all over the world. And you're starting to see health systems starting to think like that, the things they're really good at, they're really deep on, thinking about selling those services outside of the market as a way to maintain revenue. Conversely, of course, they've got to be good at all the things because all those other health systems might be trying to sell that same service into their market. So another point we wanted to make is that you can use telehealth to manage and combat privacy concerns. Admittedly, that's a double-edged sword, but you've got an electronic, prescribed way of doing things, a way of maintaining information, a way of systematically monitoring it and watching it and recording it, and that should be a help from a privacy perspective. The opposite view, of course, is that when you've got a lot of technology, you're always at the risk of hacks, and that concern is never going to go away. And so as we move into more of a reimbursement based on quality, as opposed to reimbursement based on session or provision of service, systems are trying to decrease overutilization. And of course, they're trying to lower their costs. And so telehealth, used appropriately and properly, can help that, can help on the overutilization and can help to lower costs. So that's certainly the interest for health systems. Next slide, please. So this one I'm going to do a little quicker. This is retail pharmacies using telehealth. So, the basic role of a retail pharmacy is that a doctor calls, orders a prescription, somebody comes and picks it up, okay? Telehealth can change all that, and it can quite honestly expand the role of retail pharmacies. I don't know about you, but I went to CVS recently and got a flu shot, and I will admit I hadn't been in a pharmacy for a while, and that CVS, it's starting to look like a medical office. It really is. It's still got the pharmacy, but they got the place they're doing the flu shots, they got the minute clinic, they had a whole bunch of other stuff, and it's just starting to look real different than it did just a short time ago. And they're using technology and telehealth to try to expand the type of services that they provide. So retail health is clearly an area that is impacted by telemedicine.
Next slide, please. So this slide makes the point about remote patient monitoring. I think I spent a fair amount of time on that when I talked about RPM, so I'm going to skip that slide and keep going. Next slide talks about direct-to-consumer products. I mentioned the educational component, the company that I work with, the educational component, but look at my second bullet point there. Direct-to-consumer lab tests. Let's think about what the market could be for direct-to-consumer lab tests. Yep, how about COVID? That is out of control right now. Everybody is trying to figure out a way to make COVID tests available because, as you know, everybody wants to know if they have COVID. We all want to know if we're interacting with someone with COVID, and the only way to know if you have COVID is to have a COVID test. So right now, this area is on fire. I can tell you our law firm and other law firms, just from the perspective that we have, advising tons of labs and startup companies about how to get into this business. And essentially what they want to do is they want to be able to have people go onto an app, request a lab test, they send the lab test to you, you test yourself, you upload the results in a certain manner, and they give you the answer. And you're seeing tons of businesses wanting to do that. I know I described that simply. It is not simple. It is quite complicated from a technology point of view, and I can tell you it is super complicated from a legal point of view in terms of licensing, in terms of who is responsible, in terms of liability, et cetera, et cetera, et cetera. But definitely an area that's, remote, direct-to-consumer lab tests, that's an area of telehealth because they're using technology to convey the information and report the results. Next slide, please. Okay, and the last item I wanted to talk about was providers using existing devices to create platforms to gather data and create connections. So these are messaging platforms to connect clinicians, coaching. We're seeing a real increase in lifestyle coaches, wellness coaches, support for physician services, all being provided by telehealth. Serious licensing and privacy concerns associated with those types of services, but they're absolutely out there and they're absolutely happening. So that is the second part of my presentation about telehealth expansion. Let me try to just summarize that a little bit and talk a little bit about COVID. So when COVID occurred, obviously it was a jolt to our economy, but it was a huge jolt to our healthcare system on a number of levels. The first level was that that a lot of providers couldn't stay open. They couldn't staff it. They couldn't stay open. And so if you think of the most basic level of healthcare service, it would be a primary care physician. So they were struggling to stay open. And then, of course, you know that many recipients of healthcare services need those services on a regular basis. And so because of those access issues, that got to be something that was very, very difficult right away. And so I'll tell you a little story about a specialty group. I won't define the specialty because I don't want to pick on these people. But essentially, this specialty group had been having discussions about doing telemedicine for about 5 years. And when they realized that they couldn't open their office and they couldn't practice anymore, their executive director told me that they all became telemedicine experts within the next 3 days because they were forced to look at it and do it and think it through and figure out how to do it. And they were able to do it. And it was telephone calls. It was over computer. It was giving, monitoring devices and things to patients. And I can tell you in the client base that we work with here at Nixon Peabody, I've seen a huge transformation of healthcare providers in terms of their willingness to do with telehealth, in terms of the energy they're putting into it, in terms of their acceptance. And they did it because they had to in COVID. They were out of business for a couple of weeks in March and April and even into May. And they needed a way to, one, keep in contact with their patients and provide services, meet their mission, and then second, just to have a way to continue in business, generate some revenue, and make a few bucks. So they absolutely did that, and you saw that happen. You saw that happen very strongly. Going forward, I think you're not going to unring that bell. I think you're going to see a lot more willingness to do things on telehealth, especially for Medicare patients, older patients who are monitored without serious chronic conditions. You're going to see a lot of remote monitoring. You're going to see a lot of check-in appointments, either via Zoom. If they don't have a Zoom capability or audio capability, just telephone calls. And I've seen the physician community get a lot more comfortable with it. I've seen the patient community get a lot more comfortable with it. And as I said, the payers are starting to realize that can work. And not only that can work in a fee-for-service, but also in a quality reimbursement mechanism, because it leads to better care results if you have more interactions with patients. So COVID has given rise to a rapid exacerbation of how telehealth is used. There will be some fallback, but I think you will see a lot of it stick on a going forward basis. So again, now is when I would pause and look at everybody and ask if they have any questions, but I can't do that. The chat looks empty. So I will continue for maybe another five or so minutes and then turn it over to Bill. So the last part I wanted to talk about was digital deals and to lay out some of the key issues. And I've got a lot of slides on this. Too many, in my opinion. So I'm going to go through them. I'm going to go through them pretty quick and just try to talk about some of the legal issues associated with delivering care and telemedicine. So if you could switch 2 slides forward. Yep. So I want to talk about credentialing and licensing, which I haven't done at all in this process. So I've been very clear that telemedicine allows healthcare providers to reach outside of their geographic territory and based on expertise, and that can be a good thing. There are stringent and severe licensing issues associated with that. And the general rule is that a healthcare provider that requires licensure has to have a licensure from the jurisdiction in which the person lives. So, for example, if a doctor in Georgia was going to be reviewing imaging of a patient in Rhode Island, that doctor has to be licensed in Rhode Island. Okay? And so that is a hurdle. Well, I just spent a half hour extolling all the virtues of telemedicine. Now I'm going to tell you some of the problems or issues with it. And licensing is certainly one of them, licensing and accrediting. And it's not insurmountable. It certainly is not insurmountable. But in order to if we're going to keep licensing on a state-by-state basis, as we do right now for physicians and all other type of lab technicians, there's a whole range of licensure for clinical professionals. Those licensing rules apply and they have to be complied with. And as I was explaining the issue about COVID testing, so that is tremendously complicated legally because there's an issue if you ship the COVID test into a state and and the person administers is a strong word. The person manipulates the test, creates the sample, and sends it back. Well, is that delivering lab services in that state? If they take that sample and ship it to another state and it gets analyzed in that other state, does the licensing activity, is it occurring in that state? Is it occurring in the state from which the test originates? Is it occurring in all 3 states? All of those are important issues that need to get vetted. The law has started to develop to respond to them, but it could do better. It could be faster. And I think you will see that change because, as I said, the technology companies and the technology money is so strong and so great, and it's very active, and they will push for those type of changes. Okay, if you go to the next slide, please. So the next slide just gives some examples of states and federations and different things that have tried to band together on these licensing issues. You see the Nurse Lice Compact Act, the Physical Therapy Compact Act, psychology, all different ways we're attempting to get some uniformity around the licensing issue. Okay, next slide, please. So I mentioned a little earlier the privacy and security issues. Obviously, when you're using any technology, they are extreme. So from a healthcare perspective, it's both privacy and security in terms of HIPAA, but then there's all types of security just related to the transmission of the data, the use of the computers, etc. These are not small issues. These are major issues. And when you start talking about healthcare systems and you start talking about massive amounts of healthcare data, the appropriate privacy and security needs to be in place for legal compliance, and then also just from the point of view of patients and consumers and all participants in the healthcare system having the confidence and security related to using the services. Okay, next slide. Let's go one more, and yeah, even one more after that. Yeah. So this is the last one I'm going to discuss. So I've spoken a little bit about reimbursement, and you see 5 options there for reimbursement: commercial, Medicare fee-for-service, Medicare Advantage, Medicaid, cash. All different ways that you can pay for services. So if you scroll through, and I'm not going to do it because I got to give Bill some time, on Medicare has advanced slowly in what they're willing to reimburse for. I would expect that that's going to change a lot in the future. Commercial insurance has been more receptive, and they've been more receptive because they're realizing that that it can be high quality, it can be high touch, and that it can be overall lower cost. So you're starting to see commercial insurance revised to cover more telehealth. Cash reimbursement is always the best. Everybody loves cash, but if you stop and think about a telehealth transaction, there's no way to put the money on the table. There's no way to pay. And some people don't have insurance and don't have these benefits, so they'd have to use PayPal or online services or other ways to pay. So the point I want to make here is there's a range of options. You're starting to see some changes, but there needs to be a lot more changes related to payers, specifically Medicare. So I'm going to stop there and let Bill talk about some of the white-collar challenges and other legal challenges associated with telehealth. Thank you.
Thank you, Steve. So Steve just went through this wonderful explanation of how telemedicine has continued to expand and is becoming even more important in a post-COVID world. I get to hop in and tell you the doom and gloom of what happens on the dark side of this expansion. What you often see with an expansion of new technology, new fields, you see the dark side of opportunities for fraud and crime. We could just skip the next one here. So the government has realized, and as you can see from the comments from Deputy Inspector Cantrell, that telemedicine can foster efficient, high-quality care when practiced appropriately and lawfully. Unfortunately, there's been a series of schemes over the past 2 years or so that have shown very aggressive tactics for luring in susceptible individuals and beneficiaries, and using those beneficiaries as an instrumentality of kind of widespread fraud. Again, the dark side of an expansion of a new new technology. So the two most recent government investigations in this area are an overlapping investigation called Operation Double Helix and Operation Brace Yourself. As a new dad, I got to appreciate the punny nature of all of these different investigations. You know, if investigations ever need some help naming new ones, I'm your man. But we're going to look through what these different investigations we're looking into, as well as some of the typical cases that we were finding there. So the first one is Operation Double Helix. Operation Double Helix involved a bribery and kickback scheme concerning cancer genetic testing labs. So essentially, individuals or telemarketers were aggressively targeting some beneficiaries, usually elderly or disabled beneficiaries, and advertising the need for these cancer tests, regardless of whether or not these individuals had a history of cancer, were presently treating for cancer, or had any other indicators that this would be necessary. Many of the defendants in this investigation ultimately owned those telemarketing companies. They would use those telemarketing companies to identify beneficiaries, then refer those beneficiaries to their own telemedicine companies, wherein they had paid a doctor to prescribe the test and then funnel those tests to laboratories that were under common ownership as well, making a tidy profit, but never actually benefiting the ultimate patients or beneficiaries. Often these cases were also done without any real interaction with the patient. Steve went through a variety of different ways in which telemedicine is able to interact a doctor or practitioner with a patient. Most of these cases, there was no interaction whatsoever, or it was a brief phone call, insufficient to really establish what was necessary to justify these types of tests. Operation Brace Yourself is a similar scheme, but it involved durable medical equipment. So in this instance, the same type of telemarketers were targeting very similar beneficiaries and offering to them low or no cost options for orthopedic braces and the like. They were then referred to doctors of telemedicine consultants that would essentially rubber stamp doctor's orders for these types of DME and send them back out to these patients without any real consultation, examination, or what have you. Oftentimes, there were stories that people were receiving braces that they had no idea what was happening. They would just open their door, and there's a new brace on their front doorstep because someone had mined their medical information from overseas, had referred it to a doctor, an order was written, Medicare was billed, and this brace just appeared on their front doorstep. Most of the Operation Brace Yourself funds involved many different shell companies to funnel that money overseas, a bigger international component. So looking at a couple of different cases to kind of show you what this really entailed, these different investigations entailed. Khalid Satary was an owner of several different testing laboratories in Georgia, Oklahoma, and Louisiana. He was involved in the CGX cases. He hired telemarketers and was a co-owner of several telemarketers that would contact these beneficiaries and aggressively target them for these types of tests. The tests were sent out direct to consumer and then were sometimes subsequently approved by telemedicine doctors who were engaged to treat the beneficiaries. Again, these beneficiaries barely were spoken to by these doctors. The doctors were paid essentially just to approve the test. The tests were then funneled directly to his own laboratories, who then billed Medicare. These labs collectively billed Medicare for more than $547 million. Okay, there's a lot of money involved in these multiple operations. The next case that we're going to look at is Richard Garipoli. So Richard Garipoli is an owner of a telemedicine company called Lotus Health. Lotus Health, from January 2017 to September of 2019, was again targeting beneficiaries in order to conduct this CGX scheme. They billed Medicare and Medicare Advantage over $326 million, for which they were paid over $84 million for these types of tests. Doctors were contracted directly with the telemedicine company and authorized these orders as medically necessary without ever engaging in any treatment, never having a pre-existing patient relationship, oftentimes never even speaking with one of these patients. They simply rubber stamped these doctor's orders and funneled them over to the laboratories and received a kickback for each one of those. The various laboratories also then submitted, as we saw before, their own tests and reimbursement to Medicare and further drained that system. You can see it's very intermingled web between a lot of these different defendants. The immense amount of waste that is coming from this in this type of fraud. Randy Swackhammer. So Randy Swackhammer is a medical doctor who was a part of the telemedicine component of these schemes. So he originally contracts with one of the telemedicine companies as an independent contractor. He was a, quote, consulting physician that was providing telemedicine consultation. So what would eventually happen is that patient recruiters, international calling centers, and some DME providers would target the beneficiaries, advertise the need for the braces, and then upsell elderly and disabled beneficiaries to accept these free or low-cost DME braces. What did Dr. Swackhammer actually do for his consulting physician status? He was provided with unsigned prescriptions for DME that were transmitted from the telemedicine and telemarketing companies, and he would sign them and submit them back to the company. Often, again, without having any interaction with the patient. He would certify that he had previously met with them, had some sort of physical consultation, physical examination, or test, when none of this actually occurred. What was actually happening, at best, were a brief telephone conversation with a Medicare beneficiary, if at all. Anthony Securo. So Anthony Securo is another DME provider. He's a medical doctor who signed thousands of orders for DME to different Medicare beneficiaries he claimed to, quote, be treating. Basically, the reasoning for just he's signing blank medical orders without any real consultation, without any certification or actual justification that they're medically necessary. So that's where a lot of these are becoming problematic. The variety of layered issues of why this is problematic. But when you're submitting to Medicare for medically unnecessary items, but he's certifying that they are, you have a blatant fraud, right? So again, he's not providing any actual consultations. He had short telephone conversations at best, but then he certified on all of his medical records that he had performed the appropriate examinations, he had performed physical tests, and that he had these consultations with patients, that never actually occurred. The result of these thousands of open-ended orders was that Medicare was ultimately billed $23 million. So after entering into a plea agreement with the government, Dr. Securo was sentenced to 5 years probation. He has a restitution order of almost $450,000 to personally pay back as a result of the scheme. So we've talked about telemedicine. We talked about the expansion of direct-to-consumer proponents of telemedicine, and also how COVID has developed into expanding that role, right? So that post-COVID expansion was not lost on these types of fraud. So while most of these frauds occurred in 2019, we have some industrious fraudsters who saw an opportunity, diversified their portfolio, and really capitalized on a national pandemic. So in US v. Hubler, Ashley Hubler was initially a part of the CGX cases in double helix. So what she was doing was targeting these patients for CGX tests, but she was then selling the CGX tests, as a commodity. She was taking them, receiving kickbacks and reimbursements from the telemedicine companies, and then being paid out to different laboratories to get these CGX tests filled. She was getting reimbursed on a test-by-test basis. So when COVID comes around, she realizes that, hey, I can move away from or include within this the CGX test, COVID tests. But COVID tests weren't enough. What she did was she coupled a COVID test with a respiratory pathogen panel, or an RPP. The RPP was not indicative of being able to actually test for COVID, but was being pushed upon these beneficiaries as a part of the scheme. The reason for this is that it's billed and reimbursed at 4 times the rate of COVID. What she would do is send out direct to consumer these tests. They would provide her back with a sample, a completed sample. She would then, after the fact, go to a telemedicine doctor or consultant, have an order written for the test, and then sell those tests as a bundle to different laboratories. She was receiving approximately $100 to $150 for every bundled test. She has recently pled guilty and is alleged to have received approximately over $100,000 from the scheme, and she awaits sentencing. So what are we learning from this scheme or these different schemes? So first off, the similarities in the cases are pretty glaring, right? There's doctors who never saw or talked to patients, prescriptions that were routed directly to different laboratories, pharmacies, or other providers. There were patients that didn't want or need prescriptions, right? We have instances where people are just receiving things out of the blue from Operation Brace Yourself. And then there's significant kickbacks and fee splitting. This is just blatant fraud, right? I don't think anybody is sitting there saying, oh, this is kind of nuanced. No, this is pure and unadulterated fraud. But while it wouldn't get into many people's heads to commit this type of fraud, it does show that this is an issue that's going to be moving forward, right? So with the expansion of telemedicine, you're also going to have the expansion of fraud, which brings in a closer eye from many different regulators to look and see what's happening, right? So what that tells to our clients and what that tells to the medical community is that when you are engaged in telemedicine or you're getting into these types of relationships and hopping on board at this expansion, you really need to pay attention to the basics. You really need to pay attention to the contracts that you're entering into, that you're documenting every encounter appropriately, and that you're providing the type of care that's necessary in order to actually certify what you're doing. Because where a lot of medical professionals get into trouble is that their documentation isn't up to par, or it's not as thorough as it could have been. Well, in this instance, you're starting to see a more focused role of documentation and support for these different prescriptions as a justification for this fraud in the investigation. And so what we really need to have many of the medical professionals that we're representing and in the community is to say, if you're getting involved in these types of transactions or you're starting to engage in telemedicine, really pay attention to what you're doing, really make sure that your documentation is up to par, because they're going to be under a lot more scrutiny than there probably previously were due to the amount of money that's going out the door, but also these massive investigations. So quick and dirty on the bad side of telemedicine, but now's the time where we would look for any questions either to me or to Steve on anything that we've covered. I know we can, again, go to that chat box. Seeing none. Seeing none, I would be chagrined if I wasn't to tell you, and the powers that be would yank me out here. If I wasn't to tell you, this is a continuing education forms will be mailed to you along with the completion of today's presentation. The attendance verification code is MPCLE 101620. Attendees seeking continuing education credits must complete and return their certificates of attendance and evaluation forms to Vanessa York at vyork@nixonpeabody.com. Thank you very much for coming out and seeing this lovely presentation. If you have any questions, after the fact that you don't want to have addressed today, or you think of something down the road, Steve and I have our email addresses at the beginning of the slides, and we're always happy to answer any questions that you may need.